In the meantime, I'll just talk about the gist of the talk. So there are a lot of options in terms of how a patient should be tackled with a malignant pleural effusion. The starting point, as Dr. Chaturvedi said, is probably we do a pleural fluid aspiration, which could be done through a single needle or a small catheter. This is done, as Dr. Malhotra also said, to send fluid for analysis. And depending upon what malignancy we are dealing with, the chances of picking up malignancy are dependent on that. And after that, we have to look for lung re-expansion and whether the fluid is reaccumulating and how fast it is reaccumulating. Because these are two factors that will determine how to go forward, whether the patient is suitable for IPC, that is an indwelling pleural catheter, or a simple pigtail followed by pleurodesis. So that's how we majorly, determine. And I've taken some of my data and slides from the American and European Society of Thoracic Oncology, Thoracic Surgeons, Pulmonologists, and Society of Thoracic Radiology, and some certain slides from up to date as well. So the treatment goals mainly focus on how we go forward, and the focus is palliative. Treatment should mainly focus on patient-centered goals of therapy, that is a sustained symptomatic relief, improvement in quality of life, acceptability of an intervention, affordability, and preference for a less invasive procedure. The decision for pleural intervention depends upon presence of respiratory symptoms. The most common are the dyspnea and the chest discomfort or cough. Depending upon this, it could be either a symptomatic malignant pleural effusion or an asymptomatic one. The first step is actually therapeutic thoracocentesis, and it is typically performed using a needle, a catheter, under ultrasound guidance. The thoracocentesis determines the symptomatic response to drainage, the ability of the lung to re-expand completely or partially, and the rate of subsequent reaccumulation, all of which will actually inform future more definitive treatments should the effusion reaccumulate. Almost 50% of these effusions would reoccur, and almost 2/3 of them would reoccur within a month. So various options are there. It could be a repeat thoracocentesis, indwelling pleural catheter, pleurodesis, combination therapies, a partial or complete pleurectomy, or a pleuroperitoneal shunt. The below ones are actually the definitive procedures that actually result in fewer subsequent pleural procedures, fewer emergency department visits, fewer hospital admissions, and fewer pneumothoraces. So these are the various options that actually are seen, that actually are available to us. The most common one is the chest catheter drainage. And however, we need to know that most effusions will recur after catheter removal. Chest catheter drainage with pleurodesis, the response rate is 60 to 90%. Thoracoscopy with talc insufflation, again, the effusion is similar frequency as a chest catheter drainage or talc pleurodesis. Long-term indwelling pleural catheter, it leads to control of effusion and improved symptoms in most patients. And some patients may even have a spontaneous pleurodesis. That percentage is roughly around 40%. You can use the long-term pleural catheters even for pleurodesis subsequently. The pleurodesis doesn't happen spontaneously. So choosing amongst the options, the optimal option is unclear. Considerable variation exists in practice depending upon where you are practicing, and the optimal solution should be tailored to the individual patient. The factors in play that need to be considered is whether the lung is expandable or non-expandable. If a lung is expandable, the patient can undergo several therapies. However, if it is a non-expandable lung, then it is limited to a IPC drainage only. If it is a rapid reaccumulation, you need to go for a definitive drainage, either a pleurodesis or a catheter. However, if it is a slow reaccumulation and the patient is kind of responsive to tumor therapy, then you can actually do a single-time thoracocentesis again as well. Similarly, the third point is about responsiveness to the anti-tumor therapy. For tumors which are actually responsive to chemotherapy or other systemic agents, again, avoiding pleurodesis or a long-term catheter can be reasonable because these are the patients who would respond better. However, if we think that the patients would not respond to the systemic treatment, then again, drainage is an option for such patients. The patient prognosis and functional status is again important because if a poor prognosis or poor FS patients would definitely prefer a minimally invasive procedures. Again, institutional resources, expertise, and physician preference is something that also constitutes, because especially if you look at the Western countries, IPC is more popular in US, whereas a pigtail catheter followed by pleurodesis is more popular in Europe. In terms of patient preferences, this is important because if a patient has an anticipated survival of more than 2 months, then pleurodesis can actually be carried out in a single definitive procedure rather than patient having to live with the inconvenience of an indwelling catheter that requires intermittent drainage at home. Again, some patients may choose IPC because pleurodesis has got certain risk factors such as local pain, low-grade fever, chest infections, and even really respiratory distress and increased time in the hospital. So therefore, informing patients of local facility and professional charges for each approach helps the patient to decide, and it is better that you let the patient decide what is best option for them. Another important factor in our country, at least, is that the patient's family or support system should be there to care for IPC at home. So in terms of an expandable lung with rapid reaccumulation, IPC is definitely something that is an option. It provides good symptomatic relief and can induce spontaneous pleurodesis up to 40% of the patients. Patients spend little time in the hospital and is done in an outpatient procedure. It is best suited for patients who have got a shorter survival, like less than 2 months, and for patients who prefer outpatient management and a minimally invasive option. It can be also used for patients who have failed pleurodesis initially and does not preclude subsequent pleurodesis if desired. It can also be combined with talc pleurodesis as already explained. However, the disadvantage include a longer dwell time that may be weeks or months versus days of pleurodesis and infection. And it also requires the patient or caregiver perform drainage at home. So in terms of length of stay and reduced interventions, so this paper is a meta-analysis of 5 trials that almost include 550 patients, and that confirmed that compared to pleurodesis, IPC resulted in a shorter hospital length of stay and reduced frequency of repeat interventions without any survival benefit. However, a shorter length of hospital stay may not be clinically meaningful because the patients are actually draining the fluid at home, and so that's not taken into account. In addition, 3 major randomized trials found no difference in post-procedure dyspnea, chest pain, or quality of life scores between the 2 groups. In terms of complications of IPC, the bleeding, catheter blockage, catheter fracture and removal, tract metastases, and in particular infection at the point of insertion along the catheter tract or within the pleural space can be quite problematic for the patients. Infection in a meta-analysis of 5 trials, IPCs resulted in an increased risk of cellulitis compared with pleurodesis alone. In terms of loculations, a lot of patients can actually develop catheter-related infection, which may lead to further loculations, and actually then the catheter cytos are also not able to drain the fluid that well. I'll come on to it, how we can manage it. Catheter fracture, bleeding, and pneumothorax is another risk factors. So localization is something that we should not take it lightly, because majority of these patients would have indwelling catheters, and howsoever we may try hard in terms of the population that we have in India, until unless the patient and his family are from a upper socioeconomic strata, from a middle low economic strata, we have seen that these patients land up with infections and multiple loculations in the pleural space. Now, these patients are not amenable to any treatment except for instillation of streptokinase. Mind you, the first injection is pretty well tolerated by the patient, but the moment you plan to do it second time or third time, now you're looking for trouble, because these patients can have allergic reactions and severe allergic reactions like an anaphylactic syndrome. Urokinase was something pretty cheap and pretty good, but it is no longer available in India. And again, TP is something that can be done, but the cost is a major hindrance. So this is something that we can actually do. Again, we can actually push in a wire through the IPC, and this is how a wire actually goes into IPC, and these septations can be broken through the wire also. All these things actually lead to a troublesome course for the patient and leads to frequent hospital visits that was not encountered in that meta-analysis that I talked about initially. In terms of pleurodesis, it is an appropriate alternative to IPC alone, and it is actually suitable for patients with an expandable lung who have a reasonable survival more than 2 months or at least 2 to 6 months, and who prefer a more definitive and rapid procedure that minimizes future interventions. Pleurodesis is not suitable for patients who have a shorter anticipated survival, less than 2 months. It can be performed through an IPC or a normal chest tube only. The main advantage is that it is more effective within a shortened time frame than IPC alone. However, the main disadvantage is the post-procedural pain and a small but potentially serious risk factor of respiratory complications, particularly when talc is used as a sclerosant. The chest tube size, in terms of, there's enough data now that the 12 French chest tube size is as good as 24 French. Both are similar in terms of the overall data. The large bore chest tubes actually cause more patient discomfort. And again, a shorter duration of chest tube post pleurodesis. If we remove the catheter post 24 hours versus 72 hours, there was no significant difference in terms of the success of pleurodesis. So it is a standard practice now that once we do a pleurodesis, the catheter is removed the very next day. Therefore, the patient's hospital stay is also reduced. So what about the non-expandable lung? We talked about the expandable lung where we had two options. So these are the patients that are not suitable for any type of pleurodesis, and the options are only limited to drainage with an IPC. Ultrasound may actually guide IPC placement into the largest pocket of fluid to maximize symptomatic relief. And patients who decline IPC or in whom a short life expectancy is anticipated, repeat thoracocentesis can be an option. So this actually table I've taken from UpToDate that talks about both advantages and disadvantages of indwelling pleural catheter versus talc pleurodesis. Both would lead to improved symptoms. The success rate with pleurodesis is more with the talc pleurodesis versus IPC alone. The drainage duration is shorter with talc and longer with IPC. The infection risk is again more in IPC versus talc. The outpatient drain care again need to be taken with IPC and is not required with a pigtail and talc. The length of hospital stay is 0 in IPC. Patients can be undergo these procedures on OPD basis. And whereas with talc pleurodesis, you would need to admit the patient for at least 3 to 5 days. Again, patients who have a shorter lifespan, they are the ones who can be opted for IPC. And patients who we feel there's a longer lifespan, generally talc pleurodesis can be preferred in those patients. Again, pleurodesis can be eventually performed through IPC also if spontaneous pleurodesis fails. So this is actually a simplified management pathway. Once we deal with the malignant pleural effusion, we do a therapeutic aspiration. If there is improvement in dyspnea, we see whether there is a lung re-expansion. If there is no lung re-expansion, we straight away go for IPC. However, if the life survival is less than 1 month, it is better to go for repeated thoracic thoracocentesis to avoid any discomfort to the patient. However, if life survival is more, then we have a patient choice, either IPC or a pigtail followed by talc pleurodesis. IPC again, if patients prefer accelerated pleurodesis, we can offer aggressive drainage regimens and talc installation through the IPC as well. So this was all about how we choose and which catheter to be opted for, and depending on what patients. But again, this is not a comprehensive presentation. A lot of work is going on, and this is a slide that I've again taken from UpToDate that talks about a number of trials that are going as of now across the world to actually find the answer which is the best catheter, when to use it, how to use it, and where to use it. Thank you.